Thanks, Marion, and thanks to the organizers for the invitation. A bit of a challenging topic. Is therapy-induced surface antigen decline the same as naturally low surface antigen? I will say I've spent a lot of time thinking about this, trying to put together this talk, and I'm not sure I have the answer, but I'll at least go through some ideas to think about. So here are my disclosures. And so the quick answer to this is, despite our hopes, probably not is the quick answer, that it's probably not the same, but it might depend on how you get there, and certainly I think the crux of this is that different mechanisms of action are likely relevant. And an important question is whether that's actually the goal. Are we trying to exactly mimic what we see in naturally low surface antigen levels? Maybe, but not certain that that's the answer. So I think thinking through this, some questions that need to be considered is, how do we get to low surface antigen levels? So what is the mechanism of action that you're using, and is that stable once you're either on the drug and or off the drug? What are the consequences of that? And then for each of these considerations, how do they differ between the natural scenario and drug-induced declines? So let's sort of think about what happens when you get low surface antigen levels, either complete surface antigen loss or decline in natural infection. And if you sort of look at an HBV-infected hepatocyte, a lot of the clearance is going to happen by clearance of infected cells. So you can clear the virus from the infected cell with non-cytolytic clearance. You can have direct cytopathic clearance, killing of cells, and you can also just have silencing, which leads to cell turnover. So all of that takes away that infected hepatocyte effectively. Now, the alternative is this idea of transcriptional silencing. Here, the mechanisms are a little bit less clear. So here, the important thing is that at least in the natural scenario, this is not only surface antigen that is being silenced, but it's the other transcripts as well, and that may be relevant. Theoretically, you could have translational silencing. I think that's a little bit less likely, but importantly, this almost certainly happens, because if it all was the first case scenario, we would not expect to see hepatitis B reactivation with potent immune suppression, because we shouldn't have any either HBV or infected cells. And the fact that we do see this even years after spontaneous clearance or very low S levels for a long time tells us that we do have transcriptional silencing. And I think this should be really, we need more understanding of how exactly this happens. And I'll be interested to hear the immunologists weigh in on this, because this part of immune control is a little bit less well defined. But if you think about what this looks like, so you could have it downstream where you have transcriptional silencing, or at least in theory, translational silencing, or more likely it's upstream where you have transcriptional silencing of cccDNA, and probably integrated DNA as well if you're getting actual S loss. So now what happens on the therapeutic side? Now I've put the different targets in the life cycle in different colors here. In the green, I've made the case that these are the ones that I think are more likely to mimic the natural situation. So targeting something very upstream, like gene editing, destruction, or inactivation of cccDNA. And you might be surprised to see the direct antivirals targeting packaging or even a nuke, also with a similar approach, and similarly with blocking entry, whereas transcriptional targeting late-stage effects like export or immune mechanisms are more likely a distinct pathway. And so what's the case for that? Well, the argument is that, as I made the point, with the naturally low surface antigen levels, this is through loss of infected cells, transcriptional silencing, and that you have all the transcripts are low. So what happens when you do this just with a nuke? So let's just sort of look at nukes as a simple DAA strategy. And we know that with spontaneous surface antigen loss, it's fairly similar to nuke-associated antigen loss. So this is a big meta-analysis looking at least the rate of loss, and you can see that the pooled annual rate of surface antigen loss about 1% per year, and interestingly similar between patients that received long-term nuke therapy or were not treated. So that's similar. You see if they get loss with a nuke or you get loss with natural clearance, durable in similar proportions. So you can see that the probability of staying S loss, S negative, with either interferon or a nuke on the left, or with interferon, spontaneous clearance, or a nuke is very similar in either case. And finally, what it looks like is that it is the level of surface antigen which sort of drives this. So if you look at other factors before someone goes on a nuke, you can see whether they're e-antigen positive or negative, with the genotype or the HBV DNA, small numbers, but don't have a big big driving effect here, but really it's about the baseline surface antigen level and then how quickly it falls. You can see in the bottom curve that the slope is greater in those who clear. So what can we learn from the nukes? Well, the surface antigen decline is generally slow. It's roughly the same rate as we see in natural infection. You get clearance at about 1% per year. If that happens, it's durable, and the pattern is fairly similar, that you get sort of a petering out of surface antigen rather than a flare followed by clearance like we see with E seroconversion. I think that's an important distinction, that those are really different. So it suggests that maybe the mechanism of surface antigen loss with a nuke is similar to what we see in natural infection. So this is really being driven by clearance of infected cells, driven by either cell turnover and prevention of infection of new infected cells, and that really immune clearance may actually play a very similar role in these two scenarios. So if you kind of think about it, a nuke or any other direct antiviral really sort of allows people with active disease to, in quote, survive or tolerate their infection until spontaneous surface antigen clearance occurs, because it's not really accelerating it that much as allowing patients to get to that point. So if you sort of think about any direct antiviral, you can sort of think about putting in a nuke here, and all that's doing is blocking DNA replication, but what it is doing is it's preventing the infection of new cells. So turnover of infected cells continues to happen with minimal infection, and eventually that leads to low surface antigen levels or loss. So the important point about this is it may be slow, but when you do this with a DAA, it might be much more similar to naturally low surface antigen levels and clearance. And I think that's worth considering, because I think there's been a little bit of less enthusiasm about using direct antivirals because of the lack of S loss with CAMs, but maybe I think thinking about this may actually be more similar to the natural surface antigen loss or low surface antigen levels is worth consideration. So, but the bigger question is, does the actual level matter? And a lot has been made of this idea that if we, from these data showing that if you can get someone below a surface antigen level of the magic number is usually 100, we know that's associated with a fairly high spontaneous clearance rate after stopping at least nukes. So then you see a lot of trials, and this is just one example, reporting that most patients start above 100, and then with an antigen-lowering therapy, you can get them below 100. So the real question is, does that actually matter? What does that actually mean when you do it with a therapy? So I think it's also important to consider that how you get there differs between the different approaches to bringing down S levels. So if you think about translational control, so the transcript targeting approaches, siRNA or antisense, you can do this later in the life cycle with subviral particles, things like NAPs, or even post-secretion with monoclonal antibodies, and all of these are going to bring down antigen levels, but they're going to do it at a different time in the viral life cycle and may have different effects, because they may have the same impact on antigen levels, but whether that will lead to the same impact on immune recovery and or other effects is less clear. So it's also important to consider whether what you're actually targeting is the same. So does it matter whether you're targeting the same surface antigen species, the small, medium, or large surface antigen? And some data suggesting that there may be differences between these. I think it's still a bit unclear, but this might be a key to distinguishing between integrated and cccDNA-derived surface antigen. Of course, whether this is upstream or downstream is potentially important. And then I also think this idea of whether other transcripts need to be low or not is important. When we see this with naturally low S levels, we see naturally low everything else as well. That's not always true when we start bringing in these new agents. And interestingly, now we see patients getting ASOs and siRNAs where the surface antigen level can be lower, sometimes even undetectable, and they're still E antigen positive. And that's kind of strange. That's not the way we usually think about hepatitis B. And I think it's important that we understand, if we're comparing these paradigms, that they're not really the same, because when you do this in the natural history, all of those transcripts are low, meaning that there really is some probably immune guided transcriptional control. And then, of course, there's this question of the chicken or the egg here, so that we know that the idea of bringing down S levels is that you're going to bring in immune recovery. But of course, it could be the other way around, that it's the immune recovery that's actually leading to the low S levels. And this is a continuing, ongoing discussion, which doesn't have a clear answer. But there are emerging data, and Adam and I discuss this all the time, that there's not really great data that low S antigen levels actually really reinvigorate the immune system. But there are slowly coming data to suggest that this might be true. This is just one paper from a couple of years ago that showed that you do see that patients who have, this is not with treatment, but lower S antigen levels below 500 or high S antigen levels above 5,000, the patients that had lower S levels were able to have a better response to HBV stimulation. Their HBV-specific T cells produced, in this case, just one figure, but were able to produce dual cytokines compared better than the high antigen level. So suggesting that that lowering S levels may still be helpful in terms of immune recovery. And maybe even if we don't get loss, really the idea of this is lowering levels will reinvigorate the immune response, and you just need to do it a little bit to sort of get you over the finish line. That's sort of the hope with this, but I guess the question is how low do you need to go? I think it's important to consider that it might not be right. And this is just an example which I'm not sure applies to actual patients, but it's a nice study that Adrian Cooper did, a PhD student with Adam, showing that if you think about the combinations, you've got to be careful about how you potentially sequence them and combine them. And what he showed here is on the left that if you give an siRNA, this is in cell culture, but you see that you get a reduction in antigen levels and replication, and you get a diminished core antigen-specific T cell responses. Now, if you give conditioned media with TLR7 or TLR8 to stimulate the response, what you see is that you enhance the core and S antigen specific responses. But if you give an siRNA with that, what you see is that you actually blunt that response in a sense that you need some antigen there to maintain the response. And obviously, whether this actually happens and whether this is truly physiologic when you replicate this experiment may be not so clear, but I think it's an important consideration when you try to think about the combinations. And then perhaps more concerningly is this question of, can we actually really hope to reinvigorate T cells and the immune response more generally? And I think a lot of data, this is just one in the Hep C field, shows that even when you take away the antigen, so we're not lowering the antigen, we're curing the patients, no trace of Hep C that we can find, and you still have this so-called immunological scar where if you stimulate those T cells, all they do is they come back to form similar to a terminally exhausted T cell, so that they're really not true memory T cells, and that's going to be a challenge. If that's all we can do when you take away antigen, can we really hope to do that by just lowering antigen levels? And Georg's going to talk about what a functionally cured T cell looks like this afternoon, so hopefully that will shed some light on this. But I think it's also important that in this, you did see a very clear difference between spontaneous clearance and treatment-induced clearance. So maybe our goal, rather than low S level, should be really more trying to mimic acute spontaneous clearance, where we know that you have very good, robust clearance and a durable protection. And then I think this sort of question of whether our goal should really be matching spontaneous low levels is also a question mark. This is a classic study from Carlo Ferrari's group many years ago, which sort of raised the question of whether nukes could reinvigorate the immune system. That's not really the focus here, but what I would really look at here is just if you look at the CD4 and CD8 T cell responses, and you see that patients that are inactive carriers, the ones that have low surface antigen levels, the goal that we're trying to achieve with our antigen-lowering therapies, actually have pretty paltry immune responses to HBV stimulation. So I think it does raise a question that when you actually get so you can see that the nuke-treated surface antigen loss were the ones that actually had the best response, and even spontaneous S clearance had less potent responses. So I think it just raises some questions about what we're actually trying to achieve. And again, the acute clearance was the most potent response. But before we lose all hope, even if they're not the same, maybe surface antigen reduction may still be beneficial. And Mark didn't talk about this combination specifically. He talked about the REEF-1 of combining an siRNA and a CAM. But the REEF-2, I think, is interesting. Again, no S loss in this study, but I do think it's interesting to look at what happened when these patients came off nukes. So if you look in the right panel, you see at the DNA or the ALT. In the gray is the patients who got placebo, and in the nuke is the combination patients. And although they didn't clear S, they didn't have the same rebound. So they sort of had this
kind of plateauing, something changed. And I think it's a question about whether there is some stability of off-treatment response and whether that's actually leading to some degree of immune control. And as we're going to hear more about this afternoon, and Mark touched on, is with the Arbutus 729 agent, you did see this recovery of T-cell responses with reducing exhausted phenotype and increasing T-cell activation. And there's a talk on this afternoon, so I won't go into it anymore. But so finally, to summarize, therapy-induced decline is likely not all that similar to naturally low surface antigen levels. I think it's probably most similar with direct-acting antivirals, nukes, CAMs, or anything else that leads to surface antigen loss through similar mechanisms to natural clearance and primarily enables it rather than accelerates it by blocking infection of new cells. But the important point here is that it may be very slow. More rapid surface antigen decline is likely fairly different from naturally low surface antigen levels. Reassuring that there's some emerging data to suggest that immune recovery is possible, but I think we have to be careful over interpreting these data. And this may be able to be enhanced by immune targeting agents. I think the message for me, as I really scoured the literature to try to find data to really compare these two scenarios, is we don't really know a lot about this, so we need more reliable immune evaluation, I would argue, with every early phase trial of new agents to understand this phenomenon. And I would encourage people doing these trials that this is going to help you. It costs you up front, but it's going to help you guide which combinations, the duration of trials, trial design, and perhaps most importantly, interpretation of your results. And a lot of these sort of hand-wavy comments about ALT flares post-treatment or whatever, indicating immune activation, these really aren't adequate. We really need to understand whether or not we're actually engaging the immune system and leading to immune control. And with that, I will finish and happy to take any questions. Thanks.